So welcome everyone to this virtual panel on the challenges to patient care and patient experience that we are facing across the healthcare system today. I'm Stephen Morales. I'm a managing director with Optimity Advisors. We are a full service consultancy that works with providers and payers to improve patient experience across the entire spectrum of patient care. I'm pleased to be joined today by two leading CEOs in the Chicago market, Karen Teitelbaum, the outgoing CEO of Sinai Chicago, and Brenda, the CEO of Rabida Children's Hospital. Our discussion today is going to center on how this pandemic has really driven changes to the way in which your hospitals and partners have had to modify their approaches to patient experience and some of the changing expectations that you may have seen among providers, patients, and caregivers. So thank you both, of course, for taking the time out of your challenging schedule. Before we begin, though, I'm sure that the attendees would love to understand a little bit more about your hospitals and what you see as the biggest impact the pandemic has had on delivery of care to date. So Brenda, maybe I'll turn it over to you to start. Just tell us a little bit about Rabida Children's Hospital and your experience.
Of course, I always love to have an opportunity to talk about Rabida, so thank you. We're what's called a specialty children's hospital, and we serve a specialized population of children and also offer very specific services. We serve kids with lifelong medical conditions, disabilities, kids who are dependent on medical technology, kids who've experienced severe trauma. And we really view ourselves as a complement to the major healthcare providers in our community. We provide inpatient transitional care services from NICUs and PICUs for kids who are stable enough to leave the ICU, but not yet ready to go home. We have specialty services for kids with sickle cell disease, diabetes, cerebral palsy, and we're also a patient-centered medical home for 4,000 children with special healthcare needs. But really what sort of envelops the entire operation is that we know and understand that families of kids with special needs and the kids themselves need a lot more than just good medical care. And we are committed to providing those services, whether it's education, whether it's nutrition, whether it's social work, whether it's car seats, whether it's behavioral health, various therapy services, and I could go on, but I know we're not here to just hear about Rabida. But that's really the overarching approach to the care we deliver. The other thing I have to always tell people is that we are the most Medicaid reliant hospital in the state of Illinois, where about 90% of our patient revenues come from the Medicaid program. But I also always say to people, if you're going to be that high, you might as well be number one. The pandemic. The pandemic has been an interesting time for all of us, right? I think in a way, one thing is it's brought out both the best and worst in people. And obviously, as a leader of an organization, we've had to identify how we help and support our workforce and our families and our friends, but also how to use rigor in making decisions to be able to keep on moving forward. The other thing that we're going to talk about a little later is, the whole use of telehealth, virtual healthcare services. I keep on telling people that is probably the best thing that COVID ever did, because it really pushed us all to evolve in that way in a much more quick fashion. And the last thing that COVID has really done for us, or we've learned from, is when we had to sit down to really think about the ways that we needed to protect our patients, our families, and our staff in terms of infection prevention. It was really an eye-opening experience about how we operated in general, not so much about going into a patient's room and washing your hands, but about sort of the entire operation in terms of access to our inpatient unit and such. And I think, really have learned a lot about that, and now have really been working on how to really not just make that an add-on, but really looking at how you can adopt these practices on an ongoing basis. So that's what I'm going to say as a beginning.
Thanks. That's a great starting point. Karen, why don't you tell us a little bit about the Sinai Health System?
Thanks, Stephen, and thanks so much for inviting us today. I do have to start with just noting what an asset La Rabida is to really to all of Illinois and certainly to Chicago. You heard just a little snippet of, and I'm not here to advertise Brenda, but I just I have to say it.
Oh, that's okay. Keep on going.
We're all friends. We're all friends.
As a healthcare colleague, really just an unbelievable facility providing care, I think, to a population that's most needed. So Sinai Chicago. So Sinai Chicago is on the west side and the southwest side of Chicago. We are the largest private safety net in Chicago. We're 103 years old, started with the same mission of taking care of vulnerable communities 103 years ago, and we're still doing that today. We are a level 1 trauma center. We're a level 3 neonatal intensive care unit, so the highest levels of technical care in those areas. We have one of only 2 freestanding rehab facilities as one of our 4 hospitals, one of only 2 in Chicago that are freestanding. We have, we're a pretty big employer on the west side. We've got 3,200 caregivers. We have a medical group that we employ. It's primarily specialists because we get our primary care, again, primarily through our federally qualified healthcare partners. What's different about Sinai Chicago, though, I think, is that we have a research institute that houses community health workers and epidemiologists doing translational research in health disparities out in the community. And then we have a community institute that has about 12 to 14 programs that are relevant for our communities. For example, a workforce development program. We have a delaying subsequent pregnancy in teenage girls. We have an elder abuse hotline. So wide variety of programs. We are, even though Brenda's number 1, we are 60% Medicaid. We are 20% Medicare. And just to be clear, we are not a children's hospital, though we have a fully accredited children's hospital, but it's not a freestanding one like La Rabida. We are 20% Medicare. We have about 12% absolutely no pay, and then the rest little bit is commercial insurance. We serve a very dense population in Chicago. It's a service area of about 1.5 million people, so essentially 1 out of every 3 Chicagoans are in the communities that we serve. And they're challenged communities. We have 7 times the unemployment rate as the rest of Chicago, and that was pre-COVID, so you can imagine what it's like now. 1 out of every 4 people report post-traumatic stress disorder from being a victim of violence or seeing violence. 1 out of every 2 people in our communities reports food insecurity, and we have a high burden of chronic disease. So challenging communities, but again, lots of opportunities to impact the health in Chicago. And Stephen, the question about the biggest impact, I was thinking about this for today, and I just keep coming back to, I know we're going to talk about a lot of aspects of care, so I'm going to hold, many of the other comments we're going to cover, but I just keep thinking about the level of exhaustion on the part of our caregivers, who, especially now with the labor shortage, people have been doing this for going on 2 years now, and they're just exhausted and still concerned about bringing the virus home. So those are some of the things that we're thinking about. How do we, and I know we're going to get more into that, but that for me is pretty much front and center these days.
Yeah, that's great. And maybe that's a great way to just continue on the conversation. So, I think when we think about the impact on the providers that are out there, the people who are on the front lines. I think in one of our previous discussions, you said this is really a human issue, right? That we're trying to solve for. So I'm curious, like from your position, like how have you tried to innovate on something like a human issue?
Well, Stephen, whenever we talk about innovation, my mind always goes to, well, it's got to be technology. And you know what, with this is going to sound just probably not very sexy and very simple, but I think it's human. It's about human support. It's about empathy. It's about compassion. And that's where we have to start. Early on, and Stephen and Brenda, I think I might have shared this with you. Early on, we may all recall that in New York City, in an emergency department, there was a physician who, after doing many, many shifts with COVID patients coming in and dying, committed suicide herself.
Mhm.
And at Sinai Chicago, we really took that very seriously. We decided we were going to support our leaders in conversations and an assessment of our caregivers at risk. And every single department across our 4 hospitals and our institutes and our medical groups were asked to have one-on-one conversations with people, to actually sit down, look them in the eye and say, how are you doing? How are you doing at home? How are you doing at work? And to just get a sense of, is this somebody who's going to need more support? We also came to have a deeper understanding of what people really needed. And it's interesting because all of us in healthcare remember, all the signs on the lawns, healthcare heroes work here, and there was food delivery after food delivery after food delivery for all of our shifts, right? Somebody in our community who runs a laundry offered to do laundry for our caregivers and said, after you get done caring for the rest of us, the last thing you should have to do is laundry. We also look for ways to be innovative about elder care, child care, and for our patients, of course, it was a horrible situation, still is, that people many times, and certainly at the beginning of the pandemic, couldn't be with their families at the end of life. So making sure people had iPads, poor substitute, but making sure there was a connection. And then finally, our chaplaincy, behavioral health, employee assistance program for all shifts, 24/7, and that still goes on today.
Interesting. Brenda, how about for you at La Rabida?
So I'm going to sort of take this from a different angle, and for a couple of reasons. Number one, our goal during all this, because we're not an acute care facility in the true sense of the word, our job was really more to keep our kids who are inpatients, our families, and our employees safe. We're pretty proud of, over this entire course of the entire COVID, we've had 3 patients with COVID, 2 right at the beginning, and 1 more recently whose mom visited her and brought it in. But this is also, but the tax on employees being ill, and then complementing that with the workforce shortage, we've really started to look at this in a little different way. We can keep on talking about the concrete things we can help employees with, but we've really started to take a look more at how we can be more interdisciplinary. And by being more interdisciplinary, we're also able to support each other more easily, in that if we can break down the silos, and that there are things that a respiratory therapist can do, but a nurse can also do, or what does a CNA do versus what does a nurse do? And we've been really working, and we continue to work on breaking down these silos. And we think that is helpful because it helps the workforce work with each other. But we really think that's a better way of delivering care to the patient. If there's less providers who can do more, not making them do extra, but it's going to be a better model of care. And we think in the long run, it is going to be a less expensive way of delivering care. So it's just something, obviously we too have worked to try to support employees. The stress of taking care of your own family, patients, and then dealing with families who have so many issues, of course, is, taxing. But we're really excited about this re-looking at who does what in the healthcare setting.
I love that idea. And I'd love to just get both of you to kind of chime in on, a lot of times I think what we're hearing around staffing shortages is that nurses, are jumping off, becoming traveling nurses, right, or other things. What you're kind of talking about bringing down the walls between different roles, does that actually help with cohesion? I mean, do you feel like, from both of your perspectives, this might be a way to kind of work better together?
Go ahead, Brenda.
I was going to say, ultimately, yes, but I have to say, in some cases, people have been sort of ingrained into sort of these silos. And what and we see, we have children who are on ventilators, who go home. And there is a nurse that comes into the home, and the family delivers all these services. There is no respiratory therapist. There are not all these other disciplines. And so we know that outside of the hospital, it can be done. So we are really working on making that happen. And actually, simultaneous to all this, we had begun, our inpatient unit is about 20 years old, and there were just a lot of things that we were looking at needing to kind of upgrade because of technology and things like that. But after this COVID has made us think about a bunch of other things to go along with it. One of the things we're doing is we're converting our whole area as the inpatient unit, and we're going to physically break down silos in the sense that there's going to be this one giant inpatient break area, and whether you're a nurse or a respiratory therapist or a physician, we're going to have a really lovely break area, but there's no reason that everybody has to have their own spaces. Or even in terms of, because the whole idea of what your workspace is, we're combining leaders of different disciplines in the same work area together. And so we're trying to really live and sort of breathe this in a different way. And COVID also, as I mentioned about, infection prevention, we always had it that people got off the elevator and then walked halfway down the unit to go to the nurse's station to say, hi, I'm here. Well, that is not a good way to, make sure for both from patient safety and infection prevention. So we're redesigning access to the unit by having sort of a welcoming area that you kind of have to go through before you can go see a patient. So COVID has really opened our eyes in that way about just making care different and better. And also for kids that are vulnerable, to have a place for them to leave their rooms, but not have to leave the unit. So a lot of that thinking really came out of COVID.
That's fantastic. Karen?
Yeah, and it's interesting because our environment is very different than Brenda's environment. We've got 2 campuses and many ambulatory sites, and given the complexity of the care that we offer, it can be, and we're also we're a teaching institution. So at any one time, we've got 100 medical students running around. We've got residents in 9 different programs. So it can be very chaotic. And then you toss on top of this how many times there's a surge and we need to pivot and we need to change a unit to house patients temporarily. I mean, anybody watching who's in healthcare, has probably gone through this. And so I'm thinking about this, and, Brenda, it's almost like diametrically opposed to what you just described, that at some point, people need a routine. They need some stability. At least I see that in our organization. So while we are not to the degree that you are, which I think is great, crossing the functional lines, it makes all the sense in the world. We're trying to build in some stability, some routine, so that it's one thing. I think that people become overwhelmed when they feel that they don't have control over their environment. If we know one thing about this pandemic, I mean, nobody has control. So we're trying to, maybe put a little bit of a fencing around that to give our caregivers more of a steady routine on what we can.
And I think it's interesting to think about, the highly specialized versus, obviously as a level 1 trauma center, you see so many different things, but it suggests there may be different ways to potentially address this. Maybe Brenda, I'll kind of go back to you because I do want to eventually come back to this idea of how we see things from the provider's perspective, which I think is really fantastic. I do want to continue a little bit on the theme of innovation, right? And you talked a little bit about iPads. You talked about outside the hospital. Can you talk to me about what kind of innovations Rabida put in place to kind of get those patients, their caregivers, comfortable once they leave Rabida?
Well, so I'll sort of move a little bit towards, telehealth. And we obviously anyone that has any physician clinic type services, we all rapidly morphed into telehealth. And then our behavioral health services were also easily morphing into telehealth. And I have to say that COVID probably helped us do that in a much more quick fashion than if we had just said this is a good thing to do, because we would have had a bunch of committees and we would have interviewed a lot of vendors and people would have had different opinions. And this way we just had to do it. But obviously that was simple. And then we sort of kept on moving and innovating. So we were able to deliver a considerable amount of physical, occupation, and speech therapy services through telehealth. What we did was through philanthropy is we procured supplies and equipment and sent them to our families' homes. So they would have the therapy ball or the crayons or whatever the therapist would primarily use. And then they were able to deliver services. So that was our first sort of, I mean, we weren't the only ones, but that was a big step forward to think about that delivery. But we've begun to use, first of all, we're really trying to say telehealth is part of the care continuum. It isn't that you do this instead of, but that there are certain visits that should be and certain that should be face-to-face and so on. But we've also used it to help have a warm handoff between since most of our inpatients are referred to us, we now do telehealth transfers where the child's at the referring hospital in their current room. The team that has been delivering care for the child at the referring hospital is in the room. Parents are in the room if they choose to be, and our team is at the other end. And even though there's been phone conversations and charts have been reviewed, this is a real warm handoff between caregivers. And it has really, and we do it a day before transfer, and then we do it a couple of days after the child is here. So it goes both ways, but it's been a great way to really get into the nuances of care. But the other things that are so useful, that often when a child gets transferred to a lower level of care, the current caregivers don't think it's possible that anyone could do it as well as they have. We see that when we discharge a child. This is the caregivers really getting an opportunity to meet each other, talk to each other, see the child in both settings. It's also a great way to just develop working relationships with referrers. So we're pretty excited about that. And then we've also used telehealth. You know, our case managers have always called families after discharge. We're now really using telehealth as a way to do a follow-up, even if the child doesn't remain with us for ongoing care, to do a telehealth visit. It's also so helpful to see actually the home environment. So it isn't just having a call and saying, is everything okay? We can ask, where did you put this piece of equipment? Do you have enough supplies? His position seems a little off. Maybe you should do this or that. So it's really helped open our eyes. And we have a clinic for kids who are dependent on technology, and the whole team meets with the family with their child at home. And it's just been so helpful in really, even though we're not touching each other, in a way people are closer.
That's very interesting. Karen?
I'm going to just talk for a moment about impactful partnerships. I said when we first started that 1 out of every 2 people in our communities reported food insecurity. And we know that during the pandemic, that was just exacerbated. And I happened to be talking with the then CEO of Sodexo, who's a partner of ours in food services and other services at the hospital. And before I knew it, we were suddenly partnering with a trucking company from another state that was going to bring us hundreds of pallets of thousands of meals for community pickup. And that's exactly what happened. And so for hours on end, over 2 days, we had community members coming in thanks to that partnership. That's something that's not going to be solved by hunger is not going to be solved by technology, right? Same thing with some of our smaller businesses in the North Lawndale area and the Pilsen Little Village area, the communities that we serve. They did not necessarily have access to protective equipment, didn't have the resources. They don't typically have an education department about how do you bring people into the business or into work safely. So we partnered with those businesses to help the community in terms of those areas. And whereas we, fortunately, received many, many donations of safe protective equipment.
Yeah.
We were able to share that with our community. And then when the vaccination came, we pivoted to vaccines. We had a mobile van. We went into the community. We're talking a little bit about this, I think, before we started this webinar. We were at the barbershops. We were at the gas stations. We were engaging the community leaders, whether it's faith-based. We had performance artists. We actually had distance dance parties. But these were the kinds of innovative things that we put into place externally to really engage the community around education and vaccine and how to live day to day safely, certainly at the beginning of the pandemic. And then with technology, we have community health workers. We've been using them for 20 years before there even was such a profession. And our community health workers, of course, have always done their work going into the home to assess the home environment and do education. And we had to pivot to using iPads and to using technology in that way, similar to telehealth, but doing a lot of communication, teaching, and then also coordination of care through our community health workers, but using technology.
So let me continue on the idea of teaching, right? Because I think there's the common theme sort of between, both of what you said, from Brenda's perspective, like seeing the home environment, teaching, do you actually have the things in the right place? But also, I'm very fascinated, Karen, when we think about the going out to the community and doing these distance dance parties, things that seem very social, but may actually smooth the pathway to having that education. Because let's be honest, the education, health literacy levels in underserved communities or just communities in general is very low, right? So when you think about some of the future patient experiences that are going to be out there, do we think that hospitals are going to have to do some more of that social support that's going to enable the education?
Oh, that's like lobbing a softball at me, Steve. Because honestly, like I am such a believer in this, and that's what Sinai has been all about. We talk a lot about community health workers, and what I love about that program is that I mentioned our high unemployment rate. And, if people don't have a steady income and they don't have a safe and reliable place to live, they don't care about coming in for their mammogram, right? They don't care about coming in for their annual physical. That is low on the need hierarchy. So this whole idea about taking people from the community, training them, educating them in chronic disease, or in this case, vaccine education, and then turning them back to to their own communities as community health workers. I think that is a huge part of our future. So it's always been part of Sinai. But we've seen the impact that having people from the communities, and while we're doing that, we're getting at that unemployment rate, giving people jobs with good benefits, including health benefits. So I think that's got to be, some of the changes that we're putting in because of the pandemic are just going to be sustainable and enduring, and it's going to be a better delivery system. But I'm a big believer in working with the community in everything that we do.
Fantastic. Yeah. Brenda, I mean, what are your thoughts about that? I mean, you're trying to get out more socially to.
Well, it is complicated. And, as Karen was talking about the community workers, there's all these new terms like social determinants of health and care coordination. And I think some of us who've been in the safety net world for a long time, this is really sort of part of our DNA and has always been part of our DNA. And it's only sort of recently, I hate to say this, become more sexy. And everyone has suddenly realized that this is important. Now, we still need to get the healthcare reimbursement system to recognize that as well, but we'll have to do another webinar to talk about that. But the community, it's impossible to do this work without understanding the community. Our community maybe is a little different because our swath is wider and we're more sort of focused on a subpopulation, but without understanding the needs. And, we had talked before, the big aha moment we had here was about diapers, because between COVID and the George Floyd murder and the, shutdown of retail, we really discovered our families had access issues, but also, and I never understood this, I guess diapers, if you have a child who's older and has disabilities, Medicaid will cover that. But for a typical family, diapers are not covered by any reimbursement social programs. And I even did a little research. Only in the state of California do they have a program that reimburses families for diapers. That is a huge need for a family, getting them, but having the resources to pay for them. And one of the things, which is sort of off this, but our own workforce here did a huge diaper drive, and we collected the equivalent either through dollars or actual diapers, 100,000 diapers, just to be able to give them out to families that needed that. But it's just one of those, you cannot deliver care, and I would say, we can talk about this later, whether it's a low-income world or just a typical the rest of the world, without really thinking about the community and life outside of just the healthcare setting.
The health, yeah, that's actually perfect way to kind of describe that. I do want to maybe shift a little bit to talking specifically around digital innovations. And I imagine that you both talked about iPads, but you probably considered like bigger things. There are a lot of interesting innovations out there for translation or engagement in different parts of the patient journey. For safety net hospitals, in the CEO role, how do you weigh spending money on a new technology like that versus some of the stuff that we're talking about, sort of the bread and butter?
It's interesting because safety nets are constantly choosing where we're going to allocate our scarce capital dollars. And this is where philanthropy is vital. Also, partnerships, city, state, federal support. We don't have the luxury that many hospitals have had in terms of being able to readily budget for and deploy. So the pandemic did push us into telehealth, which I think, as Brenda did such a good job of describing all the positives and how we're all going to continue doing that. Something a little bit, in my mind, even before that, at a more basic level, our Sinai Community Institute is working with Microsoft and our North Lawndale Community Coordinating Council, which is a grouping of community organizations in the North Lawndale neighborhood, to expand and improve internet. It doesn't do us any good to have this telehealth if on the other end the patient does not have reliable internet. So Microsoft's been a fantastic partner with us, recognizing how vital that stable internet is for health, for education, socialization, just as important. But it just hasn't always been available consistently for our community. So, we depend a lot on our, I call them our investors, our philanthropists and our foundation partners, to enable us to pick and choose and prioritize where to spend that money.
We'll come back to Brenda. How about for Rabida?
Well, again, we're very small and we're very specialized, so we kind of support the notion of others sort of trying things first and then we adopting them, because we're not a good beta, not really a good beta site even, but we do, work with other organizations to be able to move us forward. Both Rabida and Sinai are part of the Medical Home Network, an affordable care organization, and this relates more to our outpatient delivery. But through that organization, there's been efforts afoot to, again, link technology so that, you can't live in a silo again. You can have your own medical record, but if you don't have the information about what happened to the patient when they went to somebody else's emergency room or were admitted to another hospital, without having that cohesive amount of information, it just doesn't work. And if this is not a plug. I always felt one of the mistakes when we went to quote meaningful use in the whole EHR world and the federal government invested all that money, they should have mandated that the systems had to speak to each other. And instead now everybody is investing to make them speak to each other because they were almost like were barriers set up so that everybody would maybe purchase one particular product. That's just an editorial comment there. But it is, you just have to keep on thinking about, every aspect of a person's life and access to, whether it is the internet or having the devices or just about anything.
And so, such a great comment though, because interoperability is such a huge issue, right? Everywhere in the hospital, just getting information from even within the hospital, one place to another. But I think the couple people on our call today are very interested to understand. So if you have a new technology, right, and you as a CEO are trying to say, hey, this can help you, is the best way to try to deploy it or get engagement with it, to a patient who's coming into your ED? Is it to a patient who's getting discharged from your hospital? Is it to a patient that is not even, coming to the hospital at all? And trying to engage them socially and say, hey, you should really use this. It'll help keep you out of the hospital. But what are your thoughts on those sort of three options?
Yes.
And I was just going to say all of the above. Yeah.
Okay. So with the emergency department, of course, you have to get people stabilized before they're going to be able to listen to anything, right? So we put our community health workers on the back end of the visit as people are getting ready to be discharged. We are then, from the emergency department and with the patient assessing, do you have a safe place to go home to? Do you have what you need when you get home? And that would be a place at which, if we were going to engage around some kind of digital technology, that would be the place where we would do it. On the other hand, we've got, as I've talked about, people really out in the community, as we've been doing since 1919, working with the community. We feel very strongly that we don't do things for the community or to the community, but we really partner with the community. Because one of the things we have to think about is it's not just, and Brenda did such a great job of describing, the need for like hospital to hospital, to the healthcare systems to talk to each other. We also feel like we've got to talk to the homeless shelters, and we've got to talk to the food pantries, and we've got to talk to the other behavioral health units out in the community. So we try to think about it in a more global sense. What are all the things that touch the community? And where are the points of intersection for that connection, as opposed to just hospital to hospital? That's totally, table stakes. And we've got to do that.
Very interesting. Brenda, anything you want to add to that?
No, I think Karen's done a great job, and Sinai has been a leader in this, and it's a credit to Sinai because as a safety net, they have many challenges, but they see the critical nature of engaging the community in so many different ways. And of course, again, being a children's provider, the schools play such a critical role in all this, and that's one of the other areas, not so much from a technology perspective, but we spend a lot of time assisting our families in dealing with their children and their schools, whether it's teaching a teacher how to take care, knowing that a child has a chronic condition, but making sure kids are in the right school placement and families are empowered to advocate for their kids in the school setting. So, it really does take a village, and you can't function just as an institution with four walls.
It's very well said. And I do want to, as we're kind of reaching into the last 20 minutes here, I want to encourage people, if they have any questions, please to enter them into either the chat or the Q&A. So we'll be able to take those questions. But Brenda, maybe I'll just continue on with you. As we think about for hospitals and systems, like, there are some partners out there that you I'm sure undoubtedly work with who've really kind of stepped up to the plate to help you meet the needs around patient experience during the pandemic. And so I'm just curious, types of partners you think have really kind of shown, through during the pandemic, and which ones do you feel like have some room for improvement?
Well, that's a difficult question. I mean, we can go back. I was thinking about the partners or the pandemic, and I remember when the Blue Angels flew over Chicago to thank healthcare workers. But it's in so many different ways, and Karen really articulated it. Whether it was food, or at one point people were making cloth masks for us. I mean, we've evolved. People, I'm not sure where they found it, but bringing us PPE that they had for whatever reason. I don't want to know why, but I mean, obviously we made sure they were, safe. But I mean, it's at every level. Even our board, made sure that they recognized our employees and, fed them. But it also is partners just supporting us in, whether it's our the supply chain to make sure that we have what we need, and understanding how, we can't pay 5 times the cost of a whatever it is. So it really does. I mean, I don't mean me trite, but it does take a village, and it just takes a lot of different types of organizations and people, and also just somebody reaching out and asking, how are you? We personally are doing, or what can they do to help us? I just think that is so critical, and that goes with government as well. I'll just tell a quick story. When the initial dollars came out from the federal government to support healthcare providers, the first lob that the federal government took to do that was to use Medicare as the way to gauge how to reimburse the hospitals. Well, if you're a children's hospital, if you have Medicare, it's because of a really odd thing, either because you're doing dialysis or because you have a child that has a parent that is on Medicare. So our first check that we received from the federal government was like $19.90. And it was sort of, it would have been better to get zero. And I'll never forget, a bunch of the hospitals were on a call with Senator Durbin, and I mentioned that to him, and it was like, I couldn't see him because of the phone call, but I know there was fire in his eyes, and he really then became a hero. And it wasn't just for Rabida, but for any exclusive children's provider, of going back to, Department of Health and Human Services to say, you cannot just use Medicare as your way to gauge reimbursements. The easiest, because it's a federal program. But so it really takes all different kinds of people to help you get through crisis situations.
Wonderfully said. Karen? Yeah, Brenda, I never heard you tell that story. Oh my God. So something Brenda said made me think about this. I think that a lot of people in Chicago probably don't know. We're talking about collaboration, coordination in the healthcare field. And from March till June, 8 hospital CEOs in Chicago and the City Department of Public Health, and we were joined routinely by the Illinois Department of Public Health. Sometimes the mayor hopped onto the call, but 3 times a week in the evening, we would be calling to coordinate all aspects of dealing with the, talk about partnership, all aspects of dealing with the pandemic in the city. It was everything from, advising on setting up the field hospital at McCormick, to looking at capacity, whether it's bed capacity, ventilator capacity. And, remember, this was March of 2020. This is when we started doing it. And it was one of the reasons why I felt a lot of, I felt that we were in good hands. I felt that there was that kind of communication that needed to happen, that foresight of planning. Remember, we never reached the point that California, Washington, or New York reached. For one reason or another, we were ahead. So I think you talk about partnerships in the pandemic. That was certainly one that for me was very, very important. I think it was important for all of us in the city. And then, I've talked a bit about the partnerships outside, and one of the things that we've done through Sinai Urban Health Institute, which is our research institute, we did the largest door-to-door survey in English and Spanish that Chicago has ever had. It was funded by Chicago Community Trust. And we didn't just come up with the 500 questions. We had our community members give us input. Not a single question got on that survey of 500 questions unless the community deemed it relevant to the community. It didn't matter if we wanted to know it. This was for the community. And from that, we were able to shape, what were the priorities of the community, and then who needed to be around the table, because it was coming directly from our communities.
Yeah, very interesting. I think that the clear theme here, right, is that the innovation has to come from not only people you're serving, but the communities that you're working with, right? And listening and learning is really the thing that has to be done. I'm wondering though, because you're both in such an interesting position because of the heavy reliance on Medicaid. Do you have any lessons? Like, so I'm sure you sit down with your peers at hospitals like Northwestern, University of Chicago, where they have like a very different payer mix. What do you think that you've learned out of this pandemic that they need to know?
Well, we love our colleagues, but I don't know that either one of them have called. They haven't called me lately. Have they called you?
But when we talked about this before, so I thought about this, and so I have a background both in special education and marketing, and I kind of look at everything from this marketing lens, and whether you have, mostly insured patients or you have low income patients, whatever it is, you just always have to look at who your audience is. And I don't know if that's a safety net thing, but we've tried to really drill that into our workforce. And I think that's something that I think I've learned more so during COVID than I ever did before. And so it doesn't matter. It's just, you've got to look at who you're talking to. And we've recently, we have a trauma program that does long and short-term counseling for kids who've been severely traumatized. But we also have done trauma-informed care training to community organizations and other organizations, but we've also begun doing it within the hospital. And we view that through that lens because, the trauma-informed care is really looking at the traumatized person, and it doesn't have to be direct trauma. It can just be living in, segregated communities and, low-income communities, but it's that lens and looking at how you talk to a family member, no matter who you are working at the hospital, looking at treating a patient, but also how you treat each other. Mm-hmm. And somehow that, to me, although this whole trauma-informed approach really comes from these communities who have had so many issues, I think that's really applicable to any healthcare provider. And it's just sort of very rewarding to me to see our workforce sort of embarking on that. And I think that would be helpful to any organization.
All right. Wonderful. Well, that's great. So we did have a couple of questions that came through, and I'd love to, there was a question here, when you think about the patient experience before the person even becomes a patient, right? So you're obviously just members of the community. Who do you rely on to really shoulder that burden of influencing community health and patient experience? I think you talked a little bit about barbershops and going to gas stations, but who's the partner there that can really help?
Well, I think in our communities, I think the faith-based leaders have been amazing. We've had a series before COVID came. We had a regular series of ministry breakfasts to talk about the issues that are in the community and to kind of share best practices and almost like playbooks of how do we make sure that the congregations are being served and are being healthy. I think the other thing for me, and I'll go back to the community health workers because I am such a believer in this, I always say if I went knocking on a door in the community to talk to one of our community residents about diabetes, I kind of think, if I was talking to teenage girls about delaying subsequent pregnancy, nobody's going to be listening to me. But when we've got trusted members of the community that are, they live next door, and they're saying, hey, do you know about, or, I know 5 of your kids have asthma. Do you have inhalers for everybody? More often than not, we're finding that, well, no, mom only has 3 inhalers and the kids are taking turns. It's like Russian roulette, right? Hope I don't have the attack today. So I think just figuring out how to really relate with the community, not to the community, but with the community. And what assets do we already have in the community that we could leverage and rely on? Not coming from the hospital, but actually activating those already in the community.
Yeah, great. Excellent. Brenda, you're in a unique situation as a specialty children's hospital, but does the specialty children's hospital actually do outreach to the community?
Well, everybody here would like to do everything, and we try to say, we've got to kind of focus on, who we are and what we do. So our community is probably different than when you think about it. Our community might be, we call them DOVAs, disease-oriented voluntary associations. So there's like a sickle cell association. There's a couple of diabetes associations. There's the special ed programs in the school systems. So we kind of more focus on those entities as our community to kind of identify, because they've already identified individuals of interest and often parents of children that have these conditions. And that's sort of our target more than just the community at large. So that's kind of how we try to grapple with that, because it is, it is complicated, and we can't be all things to all people.
How are you trying to realistically address the problem to improve access to care and improve quality of care to the Black community?
Yeah, so let me answer that one first. So remember up top in the webinar, I said that we employ primarily specialists. So we don't have a huge number of primary care out there from which we're submitting data on preventive health care. We are seeing the patient, those patients are being seen with our partners in federally qualified health centers that are not part of Sinai. So, the issue of preventive care in our community health workers, it's not the same as putting in claims data from a primary care doc. That just doesn't happen. We, by and large, don't get paid for our community health workers. So to Noel's question, we won't show up on anything that measures like that for preventive, equitable care. But what we do have are studies, for example, with our community health workers, that for every $1 we invest, we're saving $14 on the other end in people not going to the emergency department. For breast health in our communities, we've been able to move through our community health workers and breast care navigators who are in the community where that, the data doesn't get put into any kind of database that US News is going to find. But we've been able to move the prevalence of stage 4 breast cancer, because people were waiting to come in until the lump was palpable, right? They weren't coming in for a screening mammogram. We've been able to move through our programs. We've been able to reduce that and move it down to stage 1, stage 2, where it's infinitely more treatable. So one thing I've learned of being at Sinai 15 years is that the care doesn't always get measured in like the US News and World Report or Consumer Reports or Leapfrog or anything like that, because we just do it, we're doing it outside the system, but we look at outcomes.
And can I just add to that, because again, focus on kids and kids with special needs, payers, even the government sort of operates on a year-by-year basis, new dollars, new contracts, and many of the outcomes really, you've got to do it through the, not the lifespan, but certainly through a longer period of time. We talked about sickle cell kids. We have all these programs working on non-pharmaceutical ways to manage pain. And part of that is, as you become an adult with sickle cell, A lot of times when you show up in an emergency room, they think you're a drug seeker, that they don't because you don't look like you have a disease. And we're trying to figure out ways that you may not need the medication, or we have programs where we can avert having orthopedic surgery and a child can walk rather than use a wheelchair or walker. But that isn't going to come out in 1 year's worth of data. And so a lot of this stuff really needs longitudinal, long-term research. And also so therefore, those of us who are trying to be doing prevention, I always call it secondary prevention, so that we can actually get paid to do these things. Because when we do this work on, it's called serial casting, we get paid like $250 for a visit to do this casting, and it takes 3 staff, yet we're averting having orthopedic surgery, and the recovery associated with it. But there's no way that gets measured. So it's challenging.
It is challenging. It's frustrating. And, to hop onto what Brenda's saying, we get paid more to amputate a diabetic leg than I do to send a community health worker. I get paid nothing to send a community health worker to the home and get them into treatment and educate about diet and so on. And yet that's where we allocate our time and money.
And I think that's actually a perfect way to end, because when we think about the innovation, the theme here has been getting out to the community, right, and doing the things that you're not necessarily paid for in the health system as it's set up. So I want to take this opportunity to say thank you, to both of you, Karen and Brenda, for sharing your insights on this. The webinar is recorded, so we'll definitely make it available for others to see. But thank you so much for taking the time out of your schedules, but also for helping us see what the great opportunities for innovation are going to be going forward. Thanks.
Thank you.